Good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center, and thank you for joining me for Facebook Live. So today, what's on the docket? First of all, I'm going to give you an update on COVID here in the area, and then we're going to have on Dr. Jeff Thormeyer, who's an orthopedic surgeon here at CGH Medical Center, to talk about shoulders and sports injuries. So looking forward to that. But before we get to Dr. Thormeyer, here are some updates that I wanted to share with you. First of all, I think I'm going to have Matt pull up our some graphs that we had to show you today. So that's our weekly update. Top left is on the red is this week. The blue is previous weeks. Bottom left is past 2 weeks. The bottom blue is the 2 weeks before that. So it's basically a monthly kind of shot. And then on July, that one top right one, oops, go back to that one, will you, Matt? That top right one that says July 21st update is just kind of the number of cases that we have in the area. And blue's May. I think kind of orangish reddish is June. And then July is yellow. And you can see that we kind of hit our low point-ish in June, and now we're starting to go back up. That wasn't all of July even. So yeah, we're obviously moving upward and onward. Let's see the next slide if we could, Matt. Okay, so that's our positivity rate and the number of cases. And you can see the left one is Monday. The right one is yesterday, was Wednesday. 14 and 16, that was unheard of in June and most of July. So we're definitely trending back up. And one of the things that I would say about that too is I was talking to one of our hospitalist doctors and just one of our doctors, and they were just talking about, what they're hearing from folks is that, people are, I think there are more cases out there than there are positive tests. I think a family will have someone test positive, and then if other people have symptoms, they're just going, okay, well, I must have it too. So I think there's a lot more than 16 people on yesterday that if we were to check the general population that we would see. So that's that. Were there any other graphs we were going to show, Matt? I can't remember. Yeah, and that's just fully vaccinated. We're at around 43% still from what I'm hearing. So we still have some work to do. State of Illinois is over 58% fully vaccinated, but not so much in our county right now. And then that last graph is the one that we always show of who's winning, the variants or the vaccines. And I think the arrow might point in both directions right now. It's kind of a tug of war, if you will, that it's trending towards the variants, but we're still not as high as we were a number of months ago. So what other facts do I want to share about COVID today in this Delta surge? Yeah, vaccinations are available, and that's kind of the black cloud hanging over this. Yeah, thanks for putting that up, Matt. That's the black cloud hanging over all this, is that if our vaccination rate could go up, I think we're done with the surge. It's just getting people vaccinated. We know the Delta is more contagious. It looks like that now that the Delta strain has a tendency to make folks sicker. What's different with this surge too is the health departments across the country are doing these things more at a countywide level, which I think is smart instead of a one size fits all. So it's based upon what the county is having in terms of surge, in terms of what recommendations are. And I think that's good because you have such a broad span. Like Vermont has 68% of their residents are vaccinated, whereas Alabama has 34%. So you're going to have different levels of surging based upon the number of people that are vaccinated. And Illinois falls at that 58% range. So it kind of gives you a sense of that. We're seeing younger patients that are hospitalized. So at the start of 2021, 53% of the people that were hospitalized were over the age of 65. Now, 26% of the people that are hospitalized are over the age of 65, and 41% are between the ages of 18 to 49. So definitely a disease of the younger, and particularly the younger who have not been vaccinated. And we also, right now, we're having a lot of other non-COVID, seems like hospital, people need to be in the hospital, so just some sicker people in general, which just makes it more, it strains the system more when you start to add on those COVID admissions. And the final thing about just newest facts about COVID right now is we're still, now that's this Lambda thing, percent of CGH employees and patient, let's see here, Donna. Yeah, I think Donna, the last I saw it was 78%, and that was 2 or 3 months ago. Actually, Donna, I know that Tom just asked me that question today, and we're looking into that to see what our most latest numbers are in terms of employees. So would I like to see 100% vaccinated? Absolutely. And is 78% or whatever percentage we're at net higher than the county? Yeah, it is. But I'm with you. I don't disagree. I'd love to see everybody vaccinated here at the hospital. Okay, Lambda variant is of interest right now, and there's some concern about how it does in terms of people that are vaccinated. So I think the take-home point I would have for just in general is 3 things. Follow the science in terms of what you decide to do and how you go about getting vaccinated, wearing masks, and those kind of things. I know the CDC and our health and Illinois Department of Public Health are not perfect, and they're constantly trying to catch up to speed with what's going on. So the information we get from them isn't perfect. Readily acknowledge that. But it's way more perfect. It's way more on top of things. It's way more science driven than what you're going to hear from pundits, politicians, and posters. So follow the science is the first thing I would say. Second thing that kind of flows from that is please get vaccinated. It's not too late. This Delta variant, people that are by and large that are getting sick and particularly getting hospitalized and dying from this don't have to. Just get vaccinated. And we have that vaccine clinic that we posted just a few minutes ago when I was starting to talk. Monday through Friday, 8:30 to 2:30, walk in. Anybody can walk in. Health departments doing vaccines as well. Local pharmacies are doing vaccines. Please get vaccinated. And finally, Marianne, I'm wearing my mask when I'm out and I'm fully vaccinated. Great, Marianne. That's great. Great news. And so I would just say on the mask side of things, the health department just recommended, was it a couple days ago, to wear masks indoors right now with this Delta that's going on. I think that makes sense. So if you're indoors, wear a mask. It just protects you and protects the folks that you get around when you're not wearing a mask and you're inside around your family. So I think that's reasonable to do, and I strongly encourage folks to do those 3 things. Okay, so other questions about COVID as I'm talking, feel free to do that. And I wanted to say one other thing about this too. I was going to just do monthly broadcasts after next week, but I think what we're going to do is we're still going to do every week, and we're just going to, once we get done, I think next week is the last of our medical staff guests. We're just going to do 5-10 minutes, quick check-in to tell everybody what's going on with COVID and the surge that we're having right now, at least until we get through that surge. So we'll still have Facebook Live every week, just not as long a version of it. But for today, I have Dr. Thormeyer, and I want to pull him in to ask him a few questions. Hi, Dr. Thormeyer.
Hi, Bill. How are you?
I'm good. Good. Nice to have you today.
Appreciate you having me.
Yeah, glad we could do this. So Dr. Thormeyer is an orthopedic surgeon, and a lot of the work he does, not all the work that he does here at CGH, is around shoulder work, and sports injuries. So I thought we would pick his brain on some of those topics. But before we do that, I had a couple other just kind of get to know you questions for Dr. Thormeyer that I thought you might be interested in. So before your professional life started at CGH a few years ago, Jeff, I want to ask you a couple things. So what's training like to become an orthopedic surgeon? What's the process?
So after medical school, you you train for at least a minimum of 5 years. It's usually your first year. You're a surgical intern going through all the different surgical specialties. And then once you finish that year, it's a dedicated 4-year residency of orthopedics. And obviously, as you advance in the program, you get a little more responsibility, but you tend to rotate through all the different subspecialties within orthopedics, trauma, sports medicine, hand, foot and ankle, shoulder, pediatrics, spine. And then once you're done with residency, it's either a year of fellowship for certain folks that want to specialize in one particular field versus time to go to work.
Got it. What made you interested in orthopedics, Jeff?
Well, unfortunately, I think this is a common theme for some orthopods. I had a lot of experience in visits with orthopedic surgeons. So
Okay.
I had 3 shoulder surgeries before the age of 21, just related to baseball and throwing. That was sort of my first introduction, and then I found that that whole process fascinating in terms of the whole thing, diagnosis, and obviously the surgical part of it, and then that's what really caught my interest early.
Yep. And I know I'm speaking to someone who is a captain, major, colonel in the military. What is your rank right now, Jeff?
Lieutenant Colonel.
I thought so. Yeah, so we're talking to a lieutenant colonel right now. Can you talk about your experience of being an orthopedic surgeon and being in the military and what that was like?
Sure. So that essentially was my first job outside of residency. I just went to active duty and did that for a number of years. I mean, obviously in the military there are some differences, but for the most part, you're using your training to take care of folks, and depending whether you're at a post in the States, and depending on which post, you're going to see a lot of what we see here in the community in terms of fractures and arthritis and sports injuries.
Sure.
And then part of serving is, depending on what's going on in the world, is deployment. I spent a good portion of a year in Afghanistan, and obviously that is mostly trauma related. I think the experience was great, and I'm still active in it in terms of reserves, and I think that it has really set me up well to take care of folks in the community, because I've got to see a lot from a lot of different angles.
Yeah, I'll bet you have. I know the big joke is whether you or Ethan are higher ranked right now. I can't remember what the deal is.
Well, there's no joke. It's just a fact. I recently got promoted, so he's not in uniform anymore, but I still tell him he has to salute me and follow orders.
Ethan is Dr. Thormeyer's PA that works with him. So he was an active military. He was an active military for a long time too. So
he put in a full 20 years, and we worked together at Fort Leonard Wood the last 4 years.
Yeah.
And sort of decided to make this this trek together.
Yeah. Well, I thank you for serving in the military, but we're sure glad you're serving here at CGH now too.
Appreciate it.
Yeah. So let's get into some shoulder stuff to start with. Let's talk rotator cuff. So what exactly is a rotator cuff tear, Jeff?
Okay. So rotator cuff is a series of tendons around the shoulder joint. They essentially attach in the front and the top and in the back around the humeral head, which is the ball of the shoulder. And they, as tendons and our musculotendinous units, they do have roles in terms of motion. They're smaller muscles and tendons, but they help with initiation of motion, bringing the arm out in front, out to the side, and rotation. But they're also very important for just balancing the shoulder, keeping the ball or the head centered in the socket, and allows the other bigger muscles around the shoulder to do their job as well. It is a common area of disease. Unfortunately, like a lot of things in our body as we age, it's a common area that has just built-in degeneration that happens over time. The nature of what we take care of in terms of rotator cuff is on a spectrum from inflammation to chronic changes that change the nature of the tendon, to partial tears, to full thickness tears, to full thickness tears that can lead to severe arthritis. So there's a spectrum of things that we treat, and it's a very common cause of shoulder pain.
Yeah. So what would be a typical symptom that a patient who has rotator cuff issues, what would they complain of, Jeff?
Initially pain with certain motion, especially overhead stuff. Depending on how long they've had it and how severe, there certainly can be weakness involved. That tends to be when things are a little more significant. Night pain is a hallmark of, especially of rotator cuff tearing. So again, initially it's pain and dysfunction with motion and strength.
Yeah, I've had patients saying like they'd reach up to a counter, to their cabinet. They couldn't reach up to grab something from a cabinet. They had a hard time combing their hair, those type of things.
Absolutely. It's not just, when we say, weakness and problems with lifting, we're not talking about, necessarily pumping iron at the gym. We're talking about this affects a lot of, everyday tasks.
Yeah. So who gets surgery? Who gets rehab in terms of rotator cuff patients?
So rehab, in my mind, plays a role almost in every patient, regardless of where they're at on that spectrum. Because not everyone with a tear necessarily needs surgery right away. Now, and again, there are certainly instances where we're a little more aggressive with that. But strengthening, range of motion, things to do with muscles around the shoulder blade, improvement in that can often help with discomfort, with range of motion, with strengthening, whether there's a tear or not. Most tears are degenerative in nature. When we do get an acute type tear, whether it's a throwing athlete, whether it's someone who had really no symptoms of pain prior and then had some type of trauma or injury, if we go on to discover that they do have a tear, those are ones where we may not necessarily bypass therapy, but we would be more aggressive in fixing it sooner. Whereas some of the degenerative type tears, and again, what matters is, how bad is the motion, how bad is the pain, things of that nature. We would certainly have physical therapy as a very early and important component of trying to rehab someone, because avoiding surgery, is a goal for sure. It's a big surgery, it's a big recovery. And if we can get folks back in a better spot, obviously that's more paramount.
What's a typical time from surgery to when they're back to the level of functioning that they're going to have after the surgery, Jeff?
Likely a minimum of 6 months, but it's probably better to quote, 9 months to a year. And oftentimes, even with a successful surgery, this is not necessarily a return to, how the shoulder was, years before they develop pain. We're looking for an improvement, obviously, in level of discomfort and function. But it's hard to sell somebody on that we're going to return now that shoulder was, 10, 20 years ago.
Yeah. Okay, let's talk labral tears. Labral. What's a labral tear? And what kind of symptoms would patients have who have that, Jeff?
So the labrum is around the socket. It's essentially you can think of it as a cartilaginous little bumper that helps with shoulder stability. There's a number of different things that go into stability, but this is a main, what we call a static stabilizer. And the labrum can be torn, and often is torn, when folks have a shoulder dislocation. And other things can happen as well. But when that labrum becomes compromised, you've now lost a bit of a safety net there to the shoulder staying in place. and that can then lead to recurrent instability. Now, there is a specific portion of the labrum at the top of the shoulder socket that's called the superior labrum. That's where your biceps tendon actually attaches, or I should say originates in your shoulder joint. That's a little bit of a different, obviously different in terms of anatomic location, but the nature of the injury there is different as well. That tends to go along with rotator cuff tears, an area of degeneration. Often it's caused by it can be issues with throwing injuries, overhead athletes. So again, the labrum has different functions depending on what portion you're looking at.
Thank you, Christy. Nice comments for Dr. Thormeyer there. How about so like what would they feel like if you have a bad labrum? What kind of, like, if I raise my arm above my head, am I going to have like a catch or a give or a?
You certainly can, and especially with superior labrum, mechanical symptoms play sort of a hallmark depending on where your shoulder or where your arm is positioned in space and activity. Overhead stuff tends to aggravate that. With the other portion of the labrum, you can still have mechanical symptoms, but you often will get the feeling of the ball slipping out of place. And frankly, when folks have shoulder instability that is bad enough, simple positioning of the arm and folks can dislocate.
Yeah. Okay. So what's the recovery like for a labral if you're going to do some labral tear surgery?
Probably not as long as cuff, but again, this is not a surgery. Most shoulder, it's rare to have a shoulder surgery.
Just for that?
That's just that, where you're back at it at a, month, 6 weeks. So it's probably about a 6-month recovery. This is now for shoulder instability surgery. And it really depends on whether you have accompanying cartilage damage and things of that nature. But you're looking at 6 weeks in a sling, a lot of therapy, probably 6 months before you're maximized. And when we do have to repair the shoulders for instability, the number one goal is to get the shoulder stable. That often means it's a little tighter. So a lot of the physical therapy work is to try to get as much motion as we can back.
Okay. Yeah. All right. Next shoulder problem, AC joint dislocations and injuries. Can you talk about what that is and what kind of symptoms patients have that?
Sure. So AC joint refers to the acromioclavicular joint, and in layman's terms, that's where the small little joint where the clavicle right there, right on the top, where the clavicle meets the shoulder blade. And it's a small little joint, but just like every joint, has some cartilage lining it, has some ligaments that are involved in capsule. Typically, an acute injury there is a trauma right on the point of the shoulder, typically from a fall. And depending on the level of force and trauma, that an injury to the capsule and to the ligaments, in addition to producing pain, can produce a change in the normal positioning and relationship between those two bones. So we often will use x-rays from the get-go to try to get a sense for the degree of injury. And that really factors into whether something can be treated non-operatively versus something that likely will need surgery. Again, in addition to pain, it is common to have mechanical symptoms, especially when you're bringing your arm across your body, because that stresses that joint.
Like for instance, I wiped out. Jeff knows this, but I wiped out on a bicycle a couple years ago, and went over the top. And like, if I were to take my shirt off, and I landed on my shoulder, if I were to take my shirt off on the right side, over here, there'd be a step off on that side compared to that side. So that's kind of if you have an AC joint kind of problem, that's part of what you're going to see.
You'll often see sort of a notable, prominence based on the portion that's higher, and sometimes with clavicle fractures too that were treated non-operatively, you'll see a a large, pretty impressive bump.
Yeah, let's talk clavicle stuff. When and the clavicle's right through here. When do you have to have surgery on a clavicle fracture versus Plan B, or maybe Plan B is the surgery? What do you do if you have a clavicle fracture for patients?
Sure. So very common injury, and even in younger patients. This has really gone. The paradigm sort of changed in terms of treatment. I remember talking to folks that had helped train me. Back 20, 30 years ago, you never operated on a clavicle because there was a very good chance of healing. Now, what we've realized is the healing versus function afterwards, is different. But I remember one of my trainers talking about, if you ever brought up in conference when you were presenting a case back 20, 30 years ago that we should fix this, you might get kicked out of the program because everything would just heal on its own. What we found out now is there are certain injuries that do better with surgery, or we can return them to function quicker. And these tend to be the fully displaced fractures that, when I say displaced, meaning the relationship between the fracture ends are completely overriding and or shortened. Those tend to do better with surgery. Now, what factors in is age, health of the patient, because a majority of these fractures can heal on their own. So there are some strategies depending on the nature of the fracture where we would lean or at least recommend surgery. Sometimes in certain athletes, we can get them back on the field or on the court if we do fix it. Again, we're not talking, weeks, we're still talking months.
Mm-hmm. Yeah. Kind of the Aaron Rodgers deal where you have some big guy falls on you, you break your collarbone, they try to put some screws in there and hope that he gets back sooner.
Right. Think, with the thought that the hardware, the plates and screws are going to be, a little stronger, might help heal it earlier. But your body still has to heal it regardless of, how you choose to manage it.
Yeah. How about people that have frozen shoulders, Jeff? What's the deal there? And what do you typically do in those situations?
So frozen shoulder refers to a condition where, as it describes, a loss of motion around the shoulder, and this is whether the patient's trying to move it or us as providers are trying to move it. And the capsule around the shoulder essentially scars in, it tightens, it contracts for whatever reason. And sometimes this is what we call idiopathic, and we just don't really have a reason for it developing. Sometimes it could be related to a trauma or an injury. Certain folks are a little more prone, diabetics, certain endocrine diseases. But there is a typical pattern where there is stages that it moves through. There is a painful stage. There is the pain and loss of motion stage. And then the third stage is often when the pain subsides, but you still have that lack of motion. Treatment is difficult because the stages are often very long, and they're not predictable, and you can't say, oh, it's going to last this long. It's different in everybody. But sometimes we're talking, over a year for the whole process to sort of peter out. And it's hard to give, somebody, this is when it's going to improve. There are things that you can do. So in addition to therapy playing a role, injections sometimes play a role, and usually we place these in the joint, so it's inside the capsule. Anti-inflammatories. Every once in a while we'll intervene, and whether that means we take somebody to surgery, put them to sleep, manipulate to try to open up that scar tissue. It's a little more rare to have to operate on folks, but if it gets bad enough and we're not seeing that any kind of response from the other modalities, we can do that sometimes.
How effective is it to go into the operating room and basically put someone to sleep and then start moving that shoulder around, what kind of success do you have when you try to loosen things up?
It depends on why you're there. If it is just typical idiopathic frozen shoulder, it's very reasonable. I mean, you got to be careful. I mean, you're talking about something that is scarred in, and it's a rather violent set of maneuvers to try to open it up, and you got to be careful. There's risks, fractures, and you don't want to be injuring other structures. But you can often get some improvement. It's then what happens after that. It's a painful maneuver, so the patient's going to hurt afterwards. We often will do the same kind of pain modalities in terms of regional blocks with anesthesia and things like that after that, even though it's not surgical, because patients have to, whatever you get motion-wise from that procedure, we got to continue with that. So we often will take pictures of folks here. Here you are at rest. Here's where we're at after this manipulation. Sometimes we put folks in machines that are going to help them move the shoulder afterwards. You got to once you get that benefit, you got to keep it going. Unfortunately, it's a trauma to the area to break up that scar tissue.
Yeah.
And the process of freezing in the first place can often sort of restart.
Okay.
That's why we try to avoid that if we can.
Yeah, that makes sense. Okay. Well, hey, I know that you have some work to do still today, so I am going to let you get back at it, but I appreciate spending the time with us. And if folks are listening closely, they're realizing that we haven't even gotten to sports medicine kind of topics yet. Well, we have some with some of the things we're talking about, but we still have some sports medicine stuff that maybe sometime in the future I might be able to get you to come on and talk about.
Sounds like a plan.
Okay. Hey, Jeff, thanks for joining me today. And thanks for everyone for listening to our broadcast. And we will see you next week.